So basically, my name is Jessica Mearson, and I am launching this Women in WASH webinar. So exciting. And I represent, District 9980, the EWASH Club. And our, focus is on water, sanitation, and hygiene. And we support the WASH RAG group, which would be the Water and Sanitation Rotarian Action Group, and trying to facilitate happier and healthier lives and sustainable strengthening futures. So that is a little bit about our EWASH Club if you are interested. But with no further ado, let's turn it over to Dr. Danielle, and she will be walking us through her presentation. So.
Thank you so much for having me. Just to know if anything ever goes wrong, just go in the chat bar and I can with anything, but I'm going to work on sharing my screen, and then I do that, and then I see the people here, and then do you see my screen shared? Does that work?
Yeah.
Except I'm on the last slide of the presentation, not the first one, so let's see. Okay, so I'm going to talk today about water, sanitation, hygiene, and engineering and international humanitarian response, and talk a little bit about Haiti and other programs. I've been working in the sector for about 18 years. I'll talk kind of throughout about women and the role of women in WASH, but and just to say, I'm a pretty casual presenter, so feel free to break in at any time. If you have questions, or I'll kind of stop periodically and ask if there are questions to follow up. So the outline, I'll talk about WASH and health, I'll talk about humanitarian response, I'll talk about putting these together, talk about the changing paradigm in WASH, because I think the big thing right now is the human population is changing, and how we respond to WASH, both in informal settlement slums and humanitarian response. We need to change how we think of it. I have some examples from Haiti, from Kenya, and Syria, and then we'll talk a bit about engineering. So to start with the intro to health and WASH, the first thing is we've actually, over the past about 26 years, the under 5 mortality rate has fallen by more than half. And this is kind of just an incredible success of the Millennium Development Goals, of the international community of responders. And that rate has fallen both in under 5 mortality, which is death in kids under 5, infant mortality, which is death of kids under 1, and neonatal mortality, which is death in kids of 28 days or less. To put some numbers with that, we've gone from about 12.6 million deaths a year to 5.6 million, and about 15,000 under 5 deaths a day. So the trend lines are actually really good. Let me click that away. The trend lines are really good. When we look at the causes of death for kids under 5 that are occurring now in 2016, the largest piece of the pie is neonatal causes, death in the first 28 days. And that's coming from a whole mix of things. It's congenital abnormalities, it's something that went wrong in the pregnancy or delivery that maybe could or could not have been addressed with adequate prenatal care. It's something that it's sepsis from in the delivery process if someone has unclean hands, or cutting the cord with unclean scissors, or it's an infection in the first 28 days of life, like diarrhea or pneumonia. Now, an additional 7% of deaths is congenital or birth issues that cause death after 28 days. So over half of death for kids under 5 is related to kind of pregnancy and childbirth in that immediate period. Once you make it past that time, the next largest cause of death is pneumonia, acute respiratory infection, mostly from unsafe cook stoves or air pollution, so indoor or outdoor air pollution that the child is breathing, then diarrhea from unsafe water and sanitation, then malaria, mosquito-borne, then a mix of 3 diseases, meningitis, HIV/AIDS, and measles. Measles is the first fully vaccine preventable disease on this list, then injuries, and then other. And so you can see kind of if we're interested in reducing death in kids under 5, we're really looking at kind of birth, and then the main 3 are pneumonia, diarrhea, malaria for infectious diseases. Now, to narrow in a bit on diarrhea, this is a picture of my son with me in Sierra Leone when he was 6 months old. We boiled water, cooled it down, gave him a bath in this little tub. He's not so sure about it, I think, but what you'll notice about him is he's politely he's fat, and he's just chunky and fat. The pediatrician called him a rubber band baby because you see the kind of markings up and down his arms, like the little chunk. And when we see a baby like this, we think happy and we think healthy, and this is kind of what we're looking for. And the reason we kind of think that is there's a medical term called physiological reserve, which is having enough weight on your body to make it through disease. So he has plenty of physiological reserve. If he got diarrhea and lost a pound, he'd be fine, right? And so why do kids die of diarrhea? It's the youngest kids, immature immune systems, less of this physiological reserve. They don't have the reserve to make it through. They may be malnourished, protein caloric deficient, micronutrient deficient. They may get frequent infections. They had acute respiratory infection last week. They had malaria 2 weeks ago. And so there's a whole bunch of things that come together that may push the child from healthy over into death, but it's one particular thing that gets put on the death certificate. And then they live in a feces contaminated environment, and they have limited access to effective clinical care. And this is a little girl in a diarrhea hospital in Bangladesh, and you can see she's at the other end of the spectrum from my son, where she just doesn't have enough left to fight against disease. So recently our definitions of safe water changed. The Millennium Development Goals, which were, the goal was to provide safe water to prevent this disease burden, went from 2000 to 2015. They were replaced in the post-2015 context with the Sustainable Development Goals. And we've moved, rather than a binary outcome, to a ladder. So we're trying to move every person up the ladder. So at the bottom of the water ladder, in orange, we see surface water, people collecting water from ponds and rivers. Then unimproved surfaces like open wells or something that's open and not controlled in any way. Limited access is like a well or a pump, but more than 30 minutes away, so you're walking. And there's a lot of research interest right now and information in figuring out the burden of carrying water on women and children. So except in the most conservative countries, women and children are the primary water collectors. And there's questions about what's the long-term impact on neck and backs from putting 20 liters, 44 pounds of water on your head and walking with it for 30 minutes. So there's a lot of push to try and get water closer to prevent this body burden and time burden and economic burden. A basic water source is an improved water source like a pump or a well within 30 minutes of the home. And then safely managed is the goal. That's the top tier now for drinking water in the Sustainable Development Goals, which is safely managed as drinking water from an improved water source, which is located on premises. So this is about bringing water to the premise. Doesn't have to be inside the house, could be on plot, on the land, but bringing water to the house that's available when needed and free from fecal contamination. So the kind of bacterial contamination and priority contamination like fluoride or arsenic or anything else that might locally be a problem. There's equivalent ladders that I won't talk through for sanitation and a new ladder in the SDGs. It wasn't addressed in MDGs for hygiene. Okay? And so one of the things I really want to get at is safe water is water that's safe to drink in the user's cup. The goal is to, in the household, when you ask the question, can you please give me a cup of water as you would provide for your child right now? You want to make sure that water is safe to drink. And that's, this is an example of water I got in rural Ethiopia. And with the SDGs, now we're actually testing this water. We're doing microbiological testing on the water that's in the household that would be provided to children to see if that's safe and incorporating that data into the SDG metrics. So just a bit of biology. diarrhea is caused by about 32 different organisms. It's not a single cause. So it's caused by bacteria, viruses, and protozoa. So bacteria are single-celled organisms. They can live and replicate in the environment. They're about a micron, a millionth of a meter in size. So they can be filterable, and chlorine inactivates them. Because bacteria have a cell wall, and that's a lipid membrane, and the chlorine lyses the cell. It breaks that cell wall and bursts it open. Some bacteria you may have heard of: cholera, typhoid. The next set is protozoa. These are bigger. They're 3 to 10 microns in size, so they're super easy to filter. This is Giardia swimming around in your intestine. And when Giardia exits your body, it knows to put itself in a shell. So it puts itself in an oocyst or a cyst, and that shell is incredibly chlorine resistant. And so these are filterable, but pretty resistant to chlorine. That shell is protective. And some protozoa are Cryptosporidium, Giardia. The last is viruses, and viruses are very small because they're just the DNA and RNA strands free floating in the environment. They can't replicate without a host. And so chlorine will inactivate them because it breaks up the DNA and RNA, but they're tough to filter because they're so small. And so that's why the combined effect of filtration and chlorination in the United States led to, and Europe during the sanitary revolution, which happened kind of give or take 1880 to 1930, led to these huge decreases in disease in cities in the US and Europe. So this is Philadelphia, and let me see if I can do this. I can. So this is Philadelphia as it's urbanizing. During the Industrial Revolution, you see population increasing during this time period. With population increases, you see increases in the number of typhoid cases. This is a log scale, so 100,000, 10,000. 1905, there's about 10,000 typhoid cases a year in Philly. And there are cholera outbreaks in New York City. Chicago had cholera outbreaks. With filtration in the system, or in the water system, you have a 90%, a 1 log reduction. In typhoid, with chlorination, you have a 2nd log reduction. This type of graph is echoed across the US and Europe from the sanitary revolution, 1880 to 1930. It's how we eradicated epidemic disease in the West during that time. So why not do this infrastructure in all contexts? There's this huge advantages to infrastructure. You provide reliable quality water, you get disease reduction. With increased quantity and coming to the house, you have better hygiene. You clean yourself, your kids, your dishes, your house, etc. But it requires political stability and large investment of public dollars. For the 4 million people in the Boston area that are served by the Deer Island wastewater treatment plant, it was $4 billion to develop that plant. To build that plant, and it's about 200 to 300 million a year to operate it. And so it's just a huge, you think about the banking system, the loans, the grants, the government, the state, who's funding that, who's banking that, and then who's recovering those funds from user fees over time. That takes an incredible banking system support. You need terrain that's conducive. It doesn't make sense if it goes up a mountain. And you need a population density. If people are too far apart, it doesn't make sense to bring pipes in, right? The other thing, and this is what I really want to talk about because I think the world is changing a bit under our feet, you need population stability and land tenure to put in infrastructure. And right now in a lot of slums, spontaneous settlements, informal settlements, people don't have stability or land tenure, and in emergencies, we're seeing a lot of population migrations. So how do you provide for that set of population as well? So kind of to summarize all this up, I think the narratives that we currently talk about in the WASH space, there's these 2 narratives. There's the urban high income water, that you have this nice infrastructure, it comes to your house in a pretty tap, and your kids are fat, happy, and healthy. Or you're in a rural area collecting water from the surface, like this surface source in Ethiopia. You're storing it in a questionable storage situation, and your kids are sick. And then if you're in that context and can't yet get infrastructure, you work on providing a well, safe water supply, water treatment. This is a picture from Haiti using a bucket with a lid and a tap, a safe storage container, and a chlorine bottle. 1 cap goes in the container. Providing a latrine to isolate feces from the environment, or providing hand washing support. And so then you have this high income and this low income narrative. And part of the low income narrative is it to be sustainable, you need technologically verified products, you need the products to work, but you also need a cost effective implementation and consumer demand, because a lot of the products, when it's not just coming to your house and it's safe and clean and you just drink it, then you need behavior change and consumer demand and education and community health workers. And that to get sustainable programs within this context, you need a mix of all three together. So that's the end of the first section that I want to do today. And so it's probably a really good time if people have questions, just unmute yourself. I can't, the way I'm seeing this with the presentation, I can't see the text boxes. So I don't know if anybody has any questions or thoughts now before I move on to the next section.
Hello, can you hear me?
I can.
Great. One question that I had is if you were going to talk a little bit about WASH, particularly in health facilities. You pointed out that nearly 50% of the deaths occur in that first month or so, and as you know, there's many health facilities around the planet that simply just don't have WASH or clean water.
Yep. So I can talk about that in the examples at the end. I will definitely, that's a great point. And so I'll add, I have some of that at the end and we'll expand on that at the end.
Okay, thank you.
Exactly. Okay.
Hi Danielle, this is Bruce Lindsay. Can you hear me?
I can. Hi, Bruce.
So this is a good introduction on the contaminant side of it. A lot of times I hear people say, oh, we're going to put filters in. And my point would be, it's probably important to know what the diseases are that are infecting the population.
Yep.
Because there are, as you said, there's the three different, the protozoans, the bacteria, and the viruses. And so if you're treating for one thing, but the problem is another, it's probably important to know, on the data side of things, what is it that we're trying to deal with, and make sure that the treatment matches that. Because I hear a lot of times, oh, we're just going to put filters in. And I ask the question, well, what are people suffering from in that particular location? Is that really the case? And then the other point was, you mentioned, obviously the microbes are the big one that really causes a lot of problems, but I'm with the USGS doing groundwater quality work, and then typically what we see after that, it goes to those, as you mentioned, fluoride, arsenic, but also some radionuclides, manganese. I don't know if you've studied manganese. We've found that doesn't have an MCL, but it's possibly a neurotoxin now. That's really prevalent. And then, things like lead from the plumbing because of the corrosivity. So there's kind of a second tier. Okay, we got the microbes out, but then all of those other things, a lot of times they're ignored as well because the people are, so focused on that big one with the microbes. And then what happened in Bangladesh is kind of what follows.
Yeah, and I think there's really good, in a lot of contexts, you think, okay, the majority of the death right now is coming from the microbiology, but then, okay, once you've erased that, how do you address the arsenic, the fluoride, a lot of places, the pesticides because of farming practices, right? So looking at all of those, both naturally occurring and human added chemicals in the environment, and what are the long-term impacts of that, and balancing out those risks, and thinking in some places, like in Bangladesh, it's true that the balance of the arsenic in cancer versus the diarrhea in kids is a really tough one to kind of figure out what's appropriate. In most places of the world, it's kind of flat out said, do the microbiology first and then address the chemistry, unless the chemistry is such a problem. But you're right, that chemistry, it's much harder to get at those contaminants. It's much harder to do that cheaply and in a low income context. And so I think right now people are focusing on the biology, but I do think the next step is the chemistry.
Right. That's one of the reasons that our group, what I'm trying to do is look at the geology of it, because as a hydrologist, I can tell what might be a problem just based on the geology of the area. If you're drilling a well in a certain rock type, you would know what to suspect. And so just some of the basic data that we have here would be really helpful in the context of developing places where, hey, let's just find out what the rocks are and then know what to look for.
And you can do some prediction of understanding before you even drill.
Yeah, the geochemistry is pretty common once you know what the basic geology is. So
Exactly. Okay, so I'm going to move on.
Sorry. Thank you very much for the presentation. It's quite resourceful. My only question is about the issues of sustainability in terms of integrating with marketing sort of wash. I'm just wondering how you have made the strategies which you have with the entrepreneurs. My question comes in because I know in one of the countries where I come from, they usually use chlorine at village level, but many times the chlorine is not there.
Right.
So I just want to know what are your plans in terms of marketing and wash to make sure that the sustainable provision of the supplies to treat the water. My other question is, I don't know whether the issues of indicators, I don't know whether this has been evaluated, what have been the key achievements so far. Thank you.
Yeah, so for sustainability, I'll talk about some example programs later, and I think that's a great question, but let me get to that. I'll give some example programs of where things are at. And then for the key indicators, right now, about 870 million people are using unimproved water sources, and about 2 billion are using safely managed sources. So we're looking at, that's kind of the top and bottom of the ladder. And I think there are great reductions in the number of people using unimproved sources, but I think there's still a long way to go. That's the indicators. But yeah, let me go on and then we'll come back to more questions. I also want to add a bit of humanitarian response here, because I think right now we're seeing much larger populations affected by humanitarian needs. We're seeing the greatest.
Danielle,
yeah.
Can I just ask everyone else to mute their video, mute themselves so that we can hear you better? Thank you.
Is that good? Yeah, okay, cool. So in humanitarian response, there's a different, we're seeing the largest number of refugees and internally displaced people we've ever seen. So I want to give a short history to humanitarian response and then talk about what we do in Washington there and how it connects. So first, humanitarian response essentially started when a man named Henry Dunant was on a battlefield in Italy and noticed that a lot of the soldiers were dying on the battlefield because they didn't have medical care. So he started the predecessor to the Red Cross and worked together with 12 governments in Europe to establish the first Geneva Convention, which allowed the Red Cross predecessor to go onto battlefields after the fight was over and provide medical care to the wounded, right? And at that time, Red Cross started with principles. They would provide medical care to those that needed it the most. They would not take sides in a war. They would not support a certain political government or not. And they would be independent. They would operate independently, right? And so ICRC was really crucial. Red Cross was really crucial in establishing international law, in naming the term NGO, non-governmental organization, in the UN Charter. That's why NGOs have, as a non-state actor, have power, is because they're named in the UN Charter. And during the Cold War, when travel was limited and whether or not you were associated with the US or the USSR meant whether or not you could go into a certain country, ICRC was able to go into all countries. And so they did a lot of response during the Cold War. At the end of the Cold War, you have a big peace dividend, you have a lot of travel opportunity, and you have many NGOs entering the aid sector, right? Suddenly the aid becomes something that people can do. And this is kind of in the 1980s. And so you have a lot of people starting to do it, right? And then in 1994, 800,000 people were killed in 100 days in the Rwanda genocide. And there were 2 million refugees. This is the fastest migration of the human population we've ever seen, that moved from Rwanda into Eastern DRC. And camps were set up here like this picture, but the aid money was diverted by the residents of the camps to continue the conflict. And cholera was very poorly treated. There was a cholera outbreak in the camp. 50,000 people died in 1 month because people didn't know how to treat cholera. They didn't know to rehydrate, right? And so the results of the kind of botched response in Rwanda was the establishment of a code of conduct and of minimum standards.
Okay, I think we're a bit frozen for a second. We'll just take a moment. Danielle, can you hear us? Oh, okay.
Am I back?
You are back. There you are. Okay, go
Did I
go ahead.
5 seconds?
You did, just for 5 seconds, but go ahead and start your screen.
I'm super sorry. So my screen is shared again, and let me find this one where I was. Okay.
Thank you. No, you're good.
So, like for the Yemen cholera outbreak and emergency, there's a humanitarian coordinator, and then there's 11 sectors. So there's a WASH sector, a WASH cluster that's headed up by UNICEF. That it's meant to coordinate, to have meetings, to provide information, to coordinate the response and to get funding. So essentially, you can email the cluster coordinator and say, "Hey, who's doing this? What should I do? Who's working where? Where are the gaps?" Right? So this cluster system is in process now and gets activated for various emergencies. The types of emergencies that it might get activated for are natural disasters like earthquakes, eruptions, etc. People think that after all natural disasters, there's going to be a lot of health impact. That's not quite true. We have really good data that shows epidemics happen after a flooding event or if there's mass displacement. But most of the time in like earthquakes and other things, people die immediately from the trauma, but then there isn't an increase in epidemics. Natural disasters are increasing their impact because of unplanned settlements, so slums, a lot of people living in marginal locations, and climate change is increasing the scale and intensity and number of disasters, particularly hurricanes, tsunamis, particularly hurricanes and all of that, flooding, drought. There's outbreaks, diseases we've seen, cholera, Ebola, Zika. Some of these are moving because of climate change. The Zika mosquitoes move because of climate change. We're seeing particular increases in cholera, particularly right now in Africa. And there's also complex emergencies in fragile states, and these are conflict areas where the government doesn't support the population. So this would be the Rohingya population in Bangladesh, the Syrian population in Syria, and this is increasing particularly in the Middle East. And we know that when there's populations that are affected by these emergencies, there's refugees, which are formally protected by international law. So that's a person who has to leave their home because of an emergency and they cross over an international border into another country. We have good literature showing how to keep the crude mortality rate of refugees down. You provide food, water, measles, vaccination, healthcare, and health info, and the mortality rate will go back down to normal. There's IDPs, these are internally displaced persons. These are people who've left an emergency but stayed within their own country. They're not formally protected by international law, and there tends to be a high crude mortality rate due to increased background diseases. So if there was a lot of diarrhea in kids before, you have a lot of death from diarrhea because you can't access medicines, you can't access physicians, medical care, etc. Similarly, if there's a lot of heart disease and diabetes, in an IDP situation, you might lose access to essential medicines and then see death from that. And then there's entrapped populations. We have entrapped populations that are behind conflict lines that are not reachable in Yemen and DRC, and very little is known about health needs and how to reach them. So just to give some examples of humanitarian, different types of needs, health needs and humanitarian response. This is South Sudan, so seeing a lot of violence and violence-affected health needs in South Sudan. This is Kosovo, so seeing a lot of needs from people with long-term medical needs, diabetes, heart disease, essential medicines, etc. And this is Haiti, where the medical needs were mostly around blunt force trauma, right? And so one of the things I want to get at is emergencies are each different in their health needs, and we don't provide, you need to think about what you provide to match. Additionally, people tend to get really alarmist around emergencies. This is after the tsunami, the South Asian tsunami. Unless the necessary funds are urgently mobilized and coordinated in the field, we could see as many fatalities from diseases as we have seen from the actual disaster itself. Actually, it was a tsunami. It was awful. 300,000 people died very quickly with the waves, but we didn't see outbreaks afterward. There wasn't flooding. The waves receded. And so the death mostly occurred in the first couple days. Right. And then another quote that I love was, another common myth about disasters is that the affected local population is helplessly waiting for the Western world to save it, when actually a lot of disaster response happens in the first couple days before anybody can get there. And so this is the digging out of people in an earthquake, etc. And so we really need to think about what the needs of the population are. And to put this together, to think about this, fortunately or unfortunately, the interventions in emergency response tend to be the same interventions we do in the development context, modified a little bit. So it's still water supply, putting in wells, rehabilitation of wells, some water trucking. It's still distribution of water treatment, putting in latrines, and promotion of hand washing. Now, we don't have a lot of evidence to show what works in humanitarian response. It's taking these responses from the development context, mostly from rural, low-income contexts, and trying to do them in emergency response. And our evidence base, I don't need you to look at this whole graph, but just to know, when we looked at 15,000 documents, trying to review to see if there's evidence on these interventions, half peer-reviewed, half gray-lit reports, we found that the evidence base is really thin. There's a lot of evidence in water treatment, particularly on aquatabs, but there's not a lot of evidence in hygiene or sanitation, and there's very little evidence in things that are only done in emergencies, like water trucking, right? Things that aren't really done in the development context. And so the evidence base is thin, and we're grabbing the evidence from the rural low-income context development sector. So I'll do this and then I'll stop for questions, because I kind of want to, and then we'll go into specific programs. But so I feel like the world is really changing. Right now, this is a picture of the African continent with the countries labeled, and then each of these circle graphs is the population in each country in cities, and the percent of the population in cities in orange that lives in slums. So you see, like, Nigeria has this big population in cities, and about 70% in slums. DR Congo, and to the bottom right there, oh, here, I can do it here. DR Congo, 75% in slums. Sudan, 90% in slums. South Africa, about 30% in slums. This is the fastest growing segment of the human population, is people living in urban slums. We cannot provide them water supply, water treatment, sanitation, and hygiene in the same way, because they do not have room. They don't have space to put in a latrine, and they do not have land tenure. We can't put anything in. And then our emergencies right now, our current emergencies, are very different emergencies than we used to have. Our emergencies right now in the world are political emergencies affecting millions of people. So these are the current emergencies for which the cluster system has been activated, and 5 of the 6 are large conflicts. Right? Yemen, 12 million people. Syria, 6 million people affected. These are DRC, 4 million people affected. These are conflicts where we're not going to go in and just hand out water treatment tablets, because there's not access and the scale is too large. The 6th conflict, Ethiopia, where famine had all but been eradicated in the human population in the last decade. There have been huge strides on the reduction of famine. And now we're looking at famine in Ethiopia and the threat of famine in Nigeria, Somalia, South Sudan, and Yemen. And so the world is really changing in the past kind of bit. And we need to think about what we do with WASH, because the populations to think about reaching are still the low-income rural populations, but we also have these emergency affected populations in conflict areas, and then we have populations in slums. And those are the kind of 3 populations that need WASH. And what do we do to reach each of those populations? So that's another good breaking point for questions. And I realized I'm in a room, and I'm going to turn the lights on, because as the sun moves up and down, I'm changing my lights. So I'm going to just turn the light switch on real quick. But does anybody have any questions after all that before we move into some specific examples of things you can do in these contexts? Or does that ring true with people, or does it make sense, or everybody's quiet?
No, I loved it. It was great. I just liked how you went, you looked at the geographics as well as, giving like the substantial information behind it. So no, fantastic. I'm eating it up.
Yes, Danielle, this is Rhonda Pierce. I am actually glad to see this presentation. I'm getting ready to go to a Kasulu area of Tanzania where there's an outbreak of the war for Congo, and a lot of the refugees are going over. They were there in 2016, over 300,000, and then I think things not settled, but they had some management of the area, and now it's just again, occurring. So as I go to see that, it's helpful to actually prepare. This presentation is a preparation for me. Actually, I wasn't expecting this. I didn't know what to expect, so I'm actually glad to see this. Thank you.
That's great. So then let me move into some specific examples. I have examples from 3 places, and I'm just gonna briefly check. Okay, 10:40, perfect. Because I'll go for about another 10 minutes, and then we'll take questions at the end. So the question of sustainability came up, and I want to get at that. When we talk about water supply and treatment, the more centralized it is, the less behavior change you have to do. The idea is you want just to provide centralized water and not have to have people think about it. You can't do centralized, maybe you can do it point of collection, maybe you can do it point of use, right? This has been a sustainable point of use treatment option that's worked really nicely in Haiti. And I want to explain what led to sustainability here. This is a bucket with a lid and a tap and a chlorine solution. It's called Guardian Low Water Guardian. This existed in Haiti before the emergencies, before the earthquake, before the cholera. They had all the materials in Haitian Creole, they had Haitian staff, they knew what they were doing, they knew how to move things around in Haiti. When the emergency happened, they took emergency response money to massively expand it. They expanded it from about 1,000 families to about 25,000 families. But they continued using the community health worker models they had. They linked into things within the country. And what we saw with this program is, and you look at this, 2010 is the year with the earthquake and cholera, 3/4 of the people who received this with community health worker visits had free chlorine residual in their drinking water. This represents about 30,000 tests over the time period, right? So going into the household, testing free chlorine residual, seeing if they're using it. 3/4 of the people were using it in 2010, and then out to 2014, which is 5 years later, you still have about half the people using it. And these are super good numbers for household water treatment, and it has to do with the fact the programs in Creole, community health workers, adequate education, adequate knowledge. If you're going to do water treatment, you need this type of long-term follow-up, and if you do it and it's appropriate for the context, you'll get nice use over time. I'm going to skip this example because I want to get to another way to be sustainable, which is to go to work with the private sector. So I've been working in this field about 18 years now. And one of the things I've noticed in the last 5 years is a huge proliferation of these kiosks in urban areas, in low-income contexts. And these kiosks, essentially, they're a tank and they're of water, and then you bring your bucket and you buy it. It's all private sector, right? This is all happening on the private. There's a demand, so the local entrepreneurs are meeting it. So they're commercially sector. They're centrally treated. So the water that comes from here isn't treated there. It's treated in a truck. They're delivered or treated in a facility. It's delivered by truck and then purchased by container. These are just, they're amazing how many of these are up in the last couple of years. And there's a lot of concern about what the water quality is. So in Haiti, CDC did a project where they walked the streets of Port-au-Prince and they visited every kiosk they found. They found 1,300 of them. Half had opened in the last year. So this is a huge growing local market. There were 4 large providers who actually, these were franchises. There were 4 large water treatment providers, like people who made the water and then cleaned the water from a source and then it was sent out. And surprisingly, and this is the positive, 91% of this water was safe to drink according to E. coli standards. And when they were able to look at the 9% that wasn't, it tied back to one of the providers. So one of the things to think about here is this is a local way to provide water to a lot of people in the absence of infrastructure. And the input points here are about regulation and testing and making sure to kind of notify, like figure out, okay, who's not providing good water, and figure out a regulatory way or a social networking way to say, okay, don't buy water there. The other thing is that water is safe in the home, right? So that's some example from Haiti, mostly on the water supply side, water treatment, water supply. I want to give some examples on sanitation and how sanitation is moving. The problem in complex emergencies, insecure land tenure slums is you don't have space to put a latrine, right? And so how do you move beyond latrines? And the big push in the WASH sector right now is moving beyond just containment to collection, treatment, and reuse. This is everything that Bill and Melinda Gates is funding in WASH is in this, collection, treatment, and reuse of sanitation. They consider it the biggest need, right? So there's two examples from Kenya, the one in a slum and one in an emergency. This is Sanergy. So they have Fresh Life defecation stations. These are put up throughout the slum, and you buy a punch card. You get 20 punches to defecate. And you go into the, I think they're actually card activated, so you swipe, right, to go into a station. And it's, they have a hand washing station, they're kept clean and fresh. You defecate, and then it's container-based defecation, right? And then that's collected. All those containers from all those facilities are collected. They're put into trucks, and they go to a treatment facility outside Nairobi, and then energy is produced, and they take the compost. And so that's reused, right? So this is about thinking, now, everybody says we're gonna get enough out of this to pay for this. I don't think that's true at all. I don't think we're gonna get anywhere near cost recovery on these, but I think sanitation has an inherent value as well within society. And so most of these are subsidized, but they're, as it is here actually in the US, but this is where it's moving. Another one is Sanovation, which is in the Kakuma refugee camp on the border of Sudan. And they actually provide a toilet into each household, into each house in the camp. And it's a nice little, it looks like a toilet. You sit, there's a container here. They collect this container weekly, and then they treat the water using solar radiation. This is a model, they have bigger ones now. And they make briquettes out of the waste, which are then sold back into the refugee camp, because the camp has no fuel source, and so this becomes a fuel source for cooking, right? Now, there's clearly a barrier there. Like, are people going to be willing to cook with their processed waste? I will say they run the best campaign I've ever seen to run money. At Christmas, they'll send you 3 briquettes and a little stocking, and you can give people a stocking full of shit for Christmas. It's a fantastic, I gave one to my mother. She didn't love it. But this sense of, will people reuse their waste for cooking, and how do we break this down? How do we get that energy back? And so I think this is really where, in some ways, things are going with sanitation. The programs right now are small, but this is the direction. It's moving beyond latrines. The last example I'll give is from Syria on water supply and conflict, right? So pre-conflict Syria is this beautiful country, right? High access to safe drinking water, high access to sanitation, poverty numbers that look like the United States, universal primary education, right? The conflict begins in March 2011, and it's amazing how fast infrastructure, in the absence of maintenance and when it's deliberately targeted as an act of war, degrades. So within 7 years now, we have almost 14 million in need of assistance, 6 million displaced, 70 million under the poverty line, 2 million need shelter, and 2/3 with no consistent access to water, right? It falls apart fast. So the WASH cluster in Syria, which operates out of Amman, Jordan, does surveys, and they're able to do surveys in areas of Syria by actually training people using WhatsApp and Skype across the border, getting materials across the border, having the data collected, and then emailing it back out. There's a lot. Yemen uses WhatsApp for some reason, and Syria uses Skype. It's amazing to see technology doing cross-border work in conflict, right? And so in 2016 and 2017, the WASH cluster and the WASH cluster partners were able to collect data, household surveys, 2,000 surveys apiece, in Dara and Quneitra in southern Syria. That data, then they need to analyze, right? And so it's sent to us at Tufts for analysis. And we saw within water supply in 2016, 77% of the country was depending on a private trucked water supply network. Now, this is in a Muslim context, and in this context, it doesn't always happen. The truckers are following the religious dictates on not doing extortionate pricing or high interest. So there's a price in the country for a certain amount of water, and that's held. There's not that price is constant. It doesn't go up and down. This water trucking network has not turned into a mafia. We've seen other water trucking networks in emergencies, Uganda and Somalia, some Muslim countries, some not, where it has turned into a mafia and we get really extortionate pricing. But in this case, there's a fixed price for water no matter where you are in Syria, if it's behind or in the conflict lines, whatever, there's a price for water. And so trucked water is accounted in 2016 for 77% of the water supply, and then 83 in 2017. The network water has gone from greater than 90 to 15% of people. It varies by region. This is just to point out that by region, this varies. It depends on what side of the conflict you're on. If you're in government-controlled areas, you have slightly more likely access to network water because the government's targeting network water in opposition areas for as an act of war. So what we really saw in Syria, and this again thinks about where do you input, the real thing is the water network has decreased, and then this water trucking has increased, and people used to be using about 80 liters, 100 liters of water a day. Now they're using about 50 liters of water a day per person in this private sector. Well, the inputs are really get chlorine in these trucks and get cash to vulnerable populations so that they can buy water from the truck network, right? And then in the infrastructure for what's left of it, pay the operators, repair and rebuild what you can, and get chlorine into that system. A big problem in Syria is chlorine is being used as a weapon of war by the government against the opposition. So chlorine is interdicted. And so the only people who can bring it in are the UN. And so the UN is trying to get chlorine in those trucks and hand it out to truckers and get chlorine into that operation station, the operators. And then when you can't get chlorine in the trucks or chlorine in the infrastructure, do household water treatment and give out tablets or whatever, but do first the truck and the operators. And we've actually seen, when you think about this risk management approach, this like try and get chlorine into every route that people may be getting water, you can get up to 90% free chlorine residual in people's households with fairly inexpensive scalable interventions from a UNICEF level, right? Because your entry points are get chlorine to the right people, train them on it, and provide cash to vulnerable populations. So I just want to end with a little bit of like engineering. Engineering is a critical piece to get humanitarian response. I do this lecture for a lot of engineers, and I try and teach them about humanitarian response. But I say engineering is the 1%, and then everything else is the 90%. The social context, the working with the right people, the behavior change, the language. You have to get that 1% right, but it's not nearly the whole solution. You have to be interdisciplinary in partnership to get the rest of the 99%. And what we see is these kind of tangible ways. A lot of people think engineers like sit in front of a computer and they do differential equations and they sit on their desk all day. But this kind of way human health and engaging engineering for health is a real tangible way to engage students. We see particularly women and minorities. We see better retention in engineering programs of women and minorities when the engineering is applied. I will say that it can be pretty emotionally difficult to work in humanitarian response, and we need to watch that when we talk about talking with students. This is my group who did a lot of the research on this project, so just some acknowledgements, but this is the time. I had 9 PhD students at the time. Right now I have 4 postdocs and 4 PhD students. And then I'll end with this quote that the notion that being humanitarian and doing good are somehow inevitably the same is a hard one to shake off. And I think when we think about what we're doing and we input at the right space to have impact, we really can do a lot of good in humanitarian response. And so that's what I have. How long did I? Okay, good. There's about 10 minutes left for questions, and maybe, I don't know, maybe people want me to keep sharing my screen so I can go to the slides. But does anybody have any questions or thoughts or responses to this?
So Danielle, when you started this whole presentation, you talked about climate change and its impact on emergencies. I was wondering, is anybody doing any mapping on frequency and location of what is happening now?
I think we have good data on hurricanes and what's likely to happen with hurricanes. We also have, there's really good maps out of the UN on affected populations, like populations that are at risk of emergencies. There's like international maps that map, like these are the areas that are at risk of emergencies and going forth in time. So I think if you emailed, I could send the link to you, or I can send a link to you of like the population, the UN has kind of mapped all this, like what populations are at risk. And then unfortunately, a lot of those areas at risk are also where we're seeing the huge human population growth.
Yeah, and I also see potential demographic shifts as a result. So when you were talking about, it's one thing to talk about the affected area by the emergency, but then all of a sudden you see this demographic shift to other populations or other countries and all that stuff, which is in your talk, you also kind of alluded to as far as providing emergency humanitarian risks too. So
exactly, and I think like right now, Jordan has as many Syrians in Jordan as they have Jordanians, right? And thinking about what that does to destabilize Jordan is like the host communities have a huge impact of this migration. And we think about in the US right now, there's government programs to move people. I mean, whether or not our government says there's climate change or not, there are government programs to move people off of islands in Louisiana that are being overtaken by water because of sea level rise from climate change, right? So there's impacted populations in the US already. And these are a couple hundred families kind of that had long-term lived on kind of isolated islands in Louisiana. But this will become much bigger as it becomes the Keys and Miami and New Orleans, right? And so I think thinking about the impact of what if New Orleans is underwater and where do all those people go is hard both for the internally displaced people and the host communities. And that leads to destabilization of governments and can lead to conflict.
Danielle, that's a good actual insight, because I mean, with Katrina and all the other, major natural disasters that we've had in country, and the movement, a lot of people went to Texas, a lot of people went to, various locations, but a good bulk of them went in certain ones. Now you have, again, the Texas hurricane, and then you have the Puerto Rico. Are we as a nation, are you hearing in the UN or I don't know where, but are the discussions happening about how to address these things? Because we're having examples, they're fairly large, but of course they're not going to be, if, like you said, Louisiana goes underwater, they're not big enough. We haven't had those examples yet, but are we preparing ourselves for that? Do you hear?
In the US, I don't think we are right now, although Puerto Rico is really an interesting example because right now I think half the population of Puerto Rico went to the mainland.
Wow, okay.
And the question is, does that population go back?
Right.
And the question is, at what point in time when half your population goes, are you not able to recover anymore? Right?
Exactly.
Because the population that goes is much more likely to be the population that's mobile, that can get a job somewhere else, that can, so you're 15 to your 45s, but grandma who's 70 and the 2-year-old and someone who has is living with a disability, they might not be able to go, they need more support, but then where's the working population to support them?
Exactly.
There's a lot of talk I'm hearing about is like, will the Caribbean, with the increase of hurricanes, and this is an interesting one. This year was both an increase of climate change. I think actually this year was both increase of climate change and just the hurricanes go up and down normally.
Right.
So, but I think we had a bad year.
Yeah.
But I think I'm really interested in the next 5 years to see what happens with the hurricanes, because if like Puerto Rico is hit like this every year,
right? Do
we maintain human habitation full-time on those islands, or do they become like tourist islands? They might have small tourist infrastructure that you pop down in for spring break. They're open for March, April, and May.
Right.
And I think because there's one island I think that there's no human habitation on anymore.
Wow.
I forget, is it Dominica? I shouldn't speak because I don't know enough, but after after the hurricane, everyone left the island, and I'm not sure if it's gone back.
Wow.
And so I think this is the type of stuff we need to think about, and I don't think currently we're talking about this in the U.S. I think the U.S. politics is so fractured right now that
Right.
conversations are about the fracture and about everything.
Right.
We're not actually thinking about preparing for
Right.
anything. And so I think, and the UN is clearly thinking about this, but I don't know. I mean, the countries most affected are the countries that are the most low income. So we talk about
Right.
Bangladesh in particular, right?
Right.
300 million people potentially impacted, and I think people know. And it's funny because I go to conferences with low income like low income country Ministry of Waters and Ministry of Health, and they know way more about climate change than anybody else because they know it's coming, right?
Right.
So it's I think there's going to be some major migrations. And then I realized I didn't answer a question before about healthcare, which is when we're looking at healthcare centers, how do we maintain infection prevention and control? And there's a huge movement right now in the SDGs to not just include the domicile, the household domicile in the metrics, but also to include both institutions, so schools, clinics, government institutions, and getting WASH into schools, clinics, and government. And that is a huge push. And part of the problem with that is they're so decentralized. Like if you think about schools, there's like a school here and a school here and a school here. And so how do you get water to those places? Is it trucked water? Is it a well? They generally tend to have space, but how do you reach, like, what kind of thing do you provide to each clinic where there's maybe 20 clinics spread across a huge area? You lose some of your geographical focus that makes it easy to program. And there's a lot of work on, UNICEF is working in schools, World Health is working in clinics. So I don't know. Yeah, so just to get at that, and I think it's great that those are finally incorporated, institutions are finally incorporated into the SDGs. Okay, does anybody else have any questions or thoughts?
Hi, Danielle. I'm Marisa Zanang. I'm currently working in the humanitarian sector. So I noticed some things you said about humanitarian work, emergency work, and refugee work. Now, these are most times the same, but sometimes they are very different. For instance, you mentioned the emergency cluster approach. Now, there is the emergency cluster approach, and there is the refugee response coordination approach. So both of these are not particularly clusters, but they happen differently depending on, for instance, which stage a refugee camp is in. So for instance, if refugees are still coming in to the camp, then it's in an active emergency state, but the camp eventually gets to a stage of just care and maintenance where you can now call it a humanitarian crisis stage. But then one other thing I was going to talk about or ask about is particularly because I used to do work in the emergency sector, but next week I'm going to Kenya and Uganda to sort out a more development work. So in this context, there is not particularly a large NGO response because you see the difference between the whole emergency and humanitarian thing going on, because there is drought in this area, fair enough, and the drought is leading to famine, yes, but it hasn't been particularly seen as a crisis or a natural disaster in that sense, despite the fact that there are millions of vulnerable people in that area. So how do you think this work that you've introduced to us will help in a more development context?
Great. And so just on definitions, the way I've heard things used is humanitarian is anything related to whether it's an emergency, like an active emergency, or an acute emergency, like 8 weeks after response, or an ongoing emergency, or a more long-term situation. That all comes under the humanitarian umbrella, which I think is why people are using the phrase more, humanitarian response. I've seen recently the change move from emergency response to humanitarian response because it's broader. No, emergency response is exactly what you say. It's like acute emergency, something happened within the last 8 weeks, or kind of the 6 months. And then you make a really good point, which is a lot of the refugee camps are actually cities. We have refugee camps. Over half of refugees are living in long-term camps. So these are camps that have been around more than 20 years, right? And so at that point in time, a refugee camp is not an emergency situation. It's a city, right? And it has its own rules and regulations and market and people who are richer and poorer. And you may or may not have migration allowed, so people may or may not be allowed to come out into the host community to work or not, to bring money in. I mean, so the refugee situations in particular, like, and then refugees can be managed by UNHCR, the UN High Commissioner for Refugees, and actually not be an emergency at all, right? If it's a long-term camp. So that makes tons of sense. Now, as for the WASH interventions that you think about in development context I see as kind of two main things to think about. One is there's high need in rural areas where there's lack of access to services, and there's incredible need in slums, in these fast growing urban settlements. And I think a lot of what's talked about today could be appropriate for slums. We know what to do in rural areas. It's a question of getting it done, right? We know exactly how to provide water and sanitation to people in rural areas. It's about the money and the resources to actually do it. In slums, we need to think about how we're going to manage the lack of access to land tenure. And then in places that are kind of teetering on famine or teetering on drought, I'd like to see more money for prevention rather than response. We tend to do much better at getting a lot of money when you see pictures of starving kids, but much worse at getting money when you see pictures of healthy kids saying this kid isn't going to have food next month. Droughts and famine are eminently predictable. We know where they're going to happen. And so it's thinking about how to get the money in before the health impacts and that preparedness. And I'd like to see us move as much to preparedness as we can, but unfortunately we don't raise as much money for preparedness as we do for response. Does that answer your question?
Yes, thank you.
Yeah. Okay. I don't know if anybody else has any.
Yeah, thank you very much. My question is about the non-sewered sanitation for the urban poor.
Yeah.
It is quite exciting because this is really a new approaches, and we have seen in some African cities that there is more cholera in the cities than in the rural areas, particularly in the slum places. I can give typical example of Zambia last year in Lusaka, where Lusaka was heavily hit by cholera. So this is quite important really as a new area for focus. I'm just wondering where you have been working this project. I have just a few questions about the projects focusing on the slum areas. To what extent have the city council been involved, because involved in a sort of transferring their responsibilities to the private sector? Because as we know, normally it has been the responsibility of the city councils in different cities in terms of, fecal sludge transport and disposal, but we are trying to say the focus should now go towards the entrepreneurs. The second question is the issue of regulation in terms of disposal of the fecal sludge. To what extent have they, what have been the positive experiences so far? And also in terms of behavior change, how are the slum dwellers accepting the issue of paying for toilets, and also even maybe using lined toilets? Because usually, normally people, we in Africa, we are used to have a pit latrine. Once it's filled, we don't bother. We just have to dig somewhere and start another afresh. Exactly. So to what extent are they accepting that? And also the use of fecal sludge pellets for cooking. To what extent are they accepting that culturally? Because sometimes there could be some resistance. I just felt I just need to know a bit more. And do you have some indicators, particularly focusing on this issue of sanitation, focusing on the slum areas? I would be very much interested to have some of them, if you don't mind. Thank you.
Yeah, absolutely. So I can send you some stuff about this to answer kind of the questions, if in order. The issues, I think you're exactly right, that a lot of people are used to latrines, and you use a latrine and it fills up and you dig another one. In a slum, you just can't do that. And when you can't do that because you don't have space to do that, then what people want, people don't use latrines because of health, because it's going to prevent disease. People use latrines and other waste disposal because of privacy. And particularly, women's privacy is often valued for defecation for safety reasons, as well as cultural reasons. And so I think if what we find is if you provide a clean and nice looking and hygienic place to defecate, that people will use it because of privacy. You know, there's some places you have to be careful. Do men and women have to be separate? There's some places, is it okay to be shared or not? Like this one is in Kibera, and so it's okay that they're shared latrines, and it's okay that they're gender shared latrines. That is not true in all contexts, but I think the fact that they're kept clean is a huge issue. People don't want them to smell. People don't want to be exposed to other people's feces. People want a hand washing station. When they're attractive, people will use them, because the other option is to defecate in the open, and particularly for women, that there's security and privacy concerns. So I think the use is not so much of a problem unless they're dirty. That's the problem we're seeing. If they're dirty, people just won't go in, right? And I think we know that. Now, in terms of the reuse for in this chain, in Sanergy, it actually goes out to farmers, and so that's fine. People don't mind. The other chain, the reason the reuse is acceptable is because there's no other thing to burn with. There's no other option. Now, if people had the option of wood or charcoal or whatever, I think they would preferentially use that, because it is weird to use your own feces. But because they're in a concept where there's no other option, it's just reused. Now, people want to pay for this privacy, but not everybody can afford it. And again, I think this is a place where vouchers can come in. Vouchers for the people who can't afford it. I can give you metrics on both of these. I think both Sanergy and Sanovation are kind of at the forefront of this. In India, there's also a bunch that are private sector, where you can go into a defecation area. People, I think the thing I would say is people don't want to deal with their own feces. They want it to go away. And when they're defecating, they want privacy. And I think that is true across the entirety of the world. So if you can make people's feces go away and give them privacy while they're doing it, right? I think then people will pay for that, or pay a small amount, or if they can, they'll pay. Or if they get a voucher, they'll use it. If you go to people and say you should use sanitary facilities to prevent cholera, it doesn't get you anywhere. Like, people don't do sanitation for health. But you make a really good point. We're seeing cholera outbreaks in urban Africa, and it's Zambia, it's Zimbabwe, it's Nairobi. We're seeing all of these urban cholera outbreaks that we hadn't been seeing before, because people are exposed to other people's waste. So we gotta find a private, clean way to make people's waste go away. That's kind of my experience. And I can send you the information. I can send you to both of these, both Sanovation and Sanergy. Part of the reason I highlight them is they both have extensive research components. So they're published in peer-reviewed papers. Sanovation works with CDC, Sanergy works with a number of organizations. These are well thought out, research-based. They're funded by Bill and Melinda Gates Foundation. They're scaling up. They're not just little projects in someone's backyard, and they're not being done with no research, so you have no idea how well it's working. These are projects that are on the right path to really have impact. They have some impact, and they're getting bigger. Yeah, thank you. I don't know if that answered all your questions. Okay. Does anybody else have any questions, or I'll come out of my share screen and come back to this.
Okay. Well, you know, if no one else has any other questions, you know, thank you so much for presenting and sharing with us all of this very vital information. And it sounds like other people are deploying into the field, and that this will be helpful to actually be put into use and applied into, you know, in the field, which is so incredibly important. it's always great to be educated on these really important aspects of, emergency contents and settings and WASH and the health of, displaced person, refugees, and then, also the, home country. And, but really being able to apply it is so incredibly important. So thank you so much for sharing with us this morning. And if anyone else has nothing else, I think we will conclude this webinar. We will be having another webinar next month. So look out for that. I'll be sending more information on that in the next week. So yeah, any last words from anyone else?
Thank you for providing the webinar. It's very informational and just really enjoyed it. Thank you.
Thank you.
As always, it's always good to see Danielle and just listen to her insights.
Yeah.
Okay.
Okay.
I hope we are having the slides very soon. Circulated to us.
Yeah.
I can send them to Jessica.
Yep, I'll send them, and then I'll be able to disperse them out to and put them, hopefully, I think, on our website as well. So I'll talk to Rob about that offline. But great, I'm so incredibly grateful. Thank you guys so much, and I think that concludes our webinar.
Okay, thank you.
Thank you. Okay.
Have a good day.
You
Okay.
too.
Bye-bye.
Bye-bye.